Okay, it's on. Okay, good morning, everybody. It's 10 o'clock, so we try to be right on time. Thank you all for coming, and I hope you understand that you're at tables because of the big dinner tonight. We are so pleased to have Dr. White with us this morning. A physician, Dr. Earl White, has been involved in medical ethics both at the clinical and organizational level since the early 90s, completing a graduate program in healthcare ethics through Rush University, Chicago. He retired from clinical medical practice in 2004 after 36 years as an orthopedic surgeon. Since that time, he has served as the medical director for healthcare ethics for Centera Healthcare and chairs the Centera Ethics Advisory Council. He is a senior ethics consultant for Centera Ethics Consult Service, overseeing clinical ethics consultations across Centera healthcare facilities. Dr. White has been a speaker at ethics venues and conferences and is published in the ethics peer-reviewed literature. He has contributed to and edited a healthcare ethics textbook. I would say he's qualified, don't you? Absolutely. He will take questions after his presentation, and we have 2 microphones we'll pass out around to whoever has a question. And please, when you get the mic, do not hold it out here because we won't be able to hear you. And Dr. White's going to remind you of this too. Hold it like this so we can hear you clear in the back. Okay, again, we're so pleased to have so many here to hear our fellow resident, Dr. Earl White.
Good morning. It's nice to see everyone. As Charlotte mentioned, well, she didn't mention this, I am really hard of hearing. Is this on now? Good. I'm really hard of hearing. So the mic is going to be crucial to continue a conversation, which is what I hope this is going to be. How do we wake this up? The computer, there we go. So the conversation today is going to be about medical ethics. Now, I'm certainly not a philosopher. I'm a clinical ethics consultant, and as such, this is the way I want to talk about the medical ethics effort with you all. So I want to make clear all of the thoughts here and the content of this presentation are just me. It's not anybody else or any other organization. This is just me. Charlotte mentioned that I have made some presentations at various conferences and so forth. Of course, when you get to this point in time, you probably haven't been doing much of that recently. But particularly with the COVID, the conferences kind of went down the tube and everything became sort of online. So let's see if we can go forward. That's backwards. Let's try this. So ethics is the philosophical study of moral thought. It's a systematic study of what's right and what's wrong from a moral perspective. And as I said, I'm certainly no philosopher. It tries to answer things, though, about what ought I to do? Why ought I to do it? And the why part's important. Or what's the good and how do I know it? Good in the sense of moral behavior and actions. So Aristotle had a quote, "The ultimate purpose in studying ethics is not about other inquiries, the attainment of theoretical knowledge." And here's my favorite quote, Medicine, even at its most technical and scientific, is an encounter between human beings, and the physician's work of diagnosing disease, offering advice, and providing treatment is embedded in a moral context. So I want to talk about clinical ethics. Healthcare ethics is a broad topic. It includes clinical ethics, organizational ethics, in other words, behavior about the company, and about research ethics. I've done some work in both of these other areas, but not a whole lot. Do have a real interest in organizational ethics, though. But the clinical ethics is really what a consultant does. He serves as a bedside person, helping people make ethical decisions about the appropriate care of patients. It's about real patients and their families, real doctors and nurses and other healthcare providers, real disagreements about what ought to be done, and real moral dilemmas. So there are lots of ways about thinking about what's right and wrong. They're divine command theories. Basically, whatever the good book, whatever that happens to be in your faith tradition, tells you to do is what you ought to do, or what God tells you to do. When it comes down to talking about bedside treatment and things of that sort, that's a great personal way to behave, and many of us have that as a background for us. But when it comes to the bedside, there are lots of different ways to think about what's right and wrong. I've listed just a few of them. Virtue ethics, well, that's classic Aristotelian ethics. But being a good person is a good idea, and good people generally make good decisions, but that doesn't necessarily work its way into the bedside care of patients. But going down the line, all of these things are different ways of thinking about what's right and wrong. Now, I'll list feminist ethics second. The theory was put out sometimes in the mid-'80s and articulated in the ethics literature, but it was the idea that women are very relational, they're compassionate, they're empathetic, they're caring, and this was typically applied to nursing. Well, I got to tell you, that's how I want my doctor to be too. So it does have broad applications. Fiduciary ethics is about duty. Well, what do you expect from me? What's my obligation to you as a healthcare provider? And going on down, I'm not going to talk about all of those things, except I've got the underlying one. Principalism as defined by Beecham and Childress. Well, that wasn't what I wanted to do. How do we get back? I don't know how that happened, but we'll figure it out. Can we turn this around so I can see that too and just put it down here? Yeah, that'd be fine. We just want to get this slideshow back up. Yeah. It's this thing right here. That's what you have to tap on. Oh, okay. Okay. Well, let's see if we can get it right now. I'm sorry about that. So it's about the real patients and real families and real problems at the bedside. And we talked about a little bit about command theories, divine command theories. And we don't think about that when it comes to secular ethics, which is what the bedside practice is all about. Principalism was articulated by Beecham and Childress in this textbook. It came out in 1978. It's now in its 8th edition, which was last in 2019. And unfortunately, Tom Beecham is now deceased. I don't know what the next edition is going to be or if. But this is basically the Bible, if you will, that's referred to most of the time in clinical ethics in Western culture in the United States. Now, the 4 principles of biomedical ethics, autonomy, non-maleficence, beneficence, and justice, you can have some simple definitions of it. Autonomy is about being in charge of you. When it comes to making decisions, you're in charge of you, and you get to make decisions that you believe to be appropriate for you at that point in that time. Non-maleficence typically applies to the caregiver side. Don't do harm, or do good. We're trying and help the people. Well, those are kind of, 10-word kind of definitions, but I will tell you that each of these in the textbook occupies some 50 pages written by philosophers. So it's very nuanced in terms of practice. Justice is about giving people what is their due. For instance, when we had the big COVID thing, the idea of what critical resource distribution was going to be like, and how do you fairly do that sort of thing. So that's not so much involved in clinical ethics as it is on the organizational level. So the patient autonomy or self-determination is first a right to refuse treatment. Don't do this to me. Or, no, I don't agree with that. Don't do this to me. It is the right to choose from among morally and medically acceptable options. It is not the right to demand, you must do this for me. So who are ethics consultants? Okay, because this is what I want to talk about, is ethics consultation at the bedside. There's a large number of different disciplines that are represented. There are nurses, there are chaplains, there are other health-related disciplines, there may be medical social workers, respiratory therapists, physicians, and I put the question mark around philosophers. And the reason I did that is to say, although the ethical theories are important, they're really foundational, bedside ethics is very much a process. And being a well-educated PhD philosopher doesn't necessarily make you the best person to solve a problem at the bedside, because the process of ethics consultation is really challenging. Now, the consultants are not moral cops. We don't go around looking for problems. We come in at invitation. I've got a problem, please help me. They don't make treatment decisions. They don't give legal advice or risk advice. What they do is they assist in conflict resolution. Because if there wasn't some conflict, nobody would pick up the phone and call us. There's a disagreement going on, and we do have some skills in that. Now, it's not the same as mediation. It's not the same as arbitration. Those are specific disciplines. But conflict resolution involves lots of different ways to go about solving the problem, but it's not that formal process. We do help people to identify morally acceptable options. And we do help make recommendations based on an analysis of the available morally acceptable options that are present in the case. So when do you call for an ethics counsel? Well, the short answer is whenever there's a question about constitutes the right choice of action. Or if the question involves a phrase, what should or what we ought to do in this situation. So some of the things that we deal with are about patients' rights and hospital policy, interpreting an advanced directive, one of these living will type documents, but they're much more expansive these days. Things like who's the right decision maker to speak for someone who can't speak for themselves when there's no advanced directive, or questions about the medical and ethically appropriateness of some treatment. There are other factors, for instance, dealing right now in a case where there's a durable do not resuscitate order, which is a specific document, and who's authorized to request and rescind that. We'll talk about that in just a little bit. Certainly there are many patients that show up in our hospital now who are unrepresented. They don't have any family. Most of us are fortunate. We live in community. The broader community where we currently live, we have families, most of us. We have loved ones. There are people, even if we don't have relatives, we mostly have people who care about us. Okay? But there are folks that show up that don't have any of that. And we need to figure out how we're going to treat those kind of people. Certainly, one of the things about brain death, I don't know, how did I go back from that? We do deal with issues of brain death, and I say that because there are ethical issues as well as the physical aspect of that. And so the concept of brain death can be very controversial, and how we explain it to people is important. How the determination is made is important. Now, I certainly don't have background as a neurologist or a neurosurgeon or critical care doctor. I'm a retired orthopod, but I've involved in this. It's about helping people understand what's the right and the wrong in terms of what should be done moving forward. So what do I do when I get a call? There are two, in most systems, excuse me, in most systems, there is a method for entering an order in the medical record. Now it's mostly electronic. And so they'll show up. Sometimes it's a phone call. Sometimes you don't have any idea where it's coming from, but you get a call. And when I find out who the person is that made the call, I'm going to answer it. I'm going to say, I'm Earl White. I'm the ethics consultant. How can I help you? Well, you say that, you're going to get a story about what's going on with the patient and what the problems are and who's not listening to you and all this stuff that's a part of what's bothering this person about this particular case. If they weren't bothered or in some kind of distress, they wouldn't call us. If everybody was in agreement, they'd march off and it'd be all good. Now, people show up with in the medical scenario, and generally things go well. The patient has a problem, they show up, the doctor or the nurse or whoever's the right caregiver talks to them, they provide the right treatment, and they recover. That is clearly not always the case. So trying to find out what the rub is for that person is really trying to get at what's the ethics question involved in this. So who gets to decide about medical treatment? Well, certainly physicians do, because they have professional knowledge and expertise, but the patient also has a lot to say about it. Now, the days of the paternalistic thing, whatever you think, doc, those days are gone. Okay? It's shared decision-making in general. And that always was there as a right, but it wasn't that way in practice. I entered when that was still sort of the way it was, and I went through a lot of the transitions over those number of years where I practiced medicine. So after I ask about what bothers you, I'm going to ask a bunch of questions, okay? Does the patient have decisional capacity? Well, why is this important? If a patient has decisional capacity, then you ask them, what do you want done? What do you think about this? How would you like to proceed? These are the alternatives. These are the risks. These are the benefits. There's this conversation. So the idea of decisional capacity really goes right back to this autonomy thing. You have a right to decide for yourself, and we have a duty to respect you as people, as a person. If the answer is no, is it documented in the record? So often, the right decision is made about who to talk to, but it's not well documented in the record. And for us, when it comes down to the bedside case consultation, having it written down is important, and how it's been done is important. I want to know if there's an advanced care plan or a living will type document. And those are really important. And I won't ask for a show of hands, but everybody in this room ought to have it done so that they make their wishes known for people when you can't speak for yourself. And we're all going to probably get at that point at some time. And finding out who's the right person to speak for you is a really important thing. It ought to be somebody you trust. It ought to be someone you've had a conversation with about what's important to you. Advanced Care Plan does several things. It names an agent. It talks about your permission for an organ donation. It usually has a living will section. If I'm terminally ill and I don't want this, that, or the other thing. But that sort of language. So if there's no advanced care plan, who gets to talk for you? Well, what we want is to respect your autonomy, and identifying someone who knows your values, knows what you would want done, is the right kind of person. The appropriate medical decision maker, though, is both a legal as well as an ethical question. And Virginia statute, the Healthcare Decisions Act, sort of outlines this for us. Now, I mentioned that document. We as ethics consultants are familiar with it in some detail so that we make recommendations that are in agreement or aligned with what the law requires. So there are occasions, of course, where the ethical thing to do is not the right thing to do as defined in the law. Just as a classic example is segregation, okay? You know, there was a moral reason to oppose that, okay? And eventually it got changed. But the law is generally what we're going to follow. So if the court has appointed somebody, that trumps everybody else. And we're talking about people to speak for the patient who cannot speak for themselves. It goes right down the line. First person, of course, is the patient with decisional capacity. Then about someone that person has named. Now, it's only when they lack capacity. So this document, which is really important and you need it, doesn't have any bearing whatsoever for you sitting in this room right now. So that your family has no true authority to direct your care as long as you can take your own decisions and make them for yourself. If there's no advanced care plan, it goes right down the line. The patient's spouse, where there's no divorce action. Well, I'm going to tell you, we run into this all the time. People who have not lived with their spouse, they've been apart for a long period of time, but if there was no divorce action filed, that person is still the statutory decision maker for you. So that's one of the real reasons. It probably doesn't apply to most of us in this room, but it's a real reason to update your plan on a regular basis. And the parens there's no common law of marriage in the state of Virginia. So that person may have been that person's life partner for years and years. They may have children together. That person who's the life partner has no authority to make medical decisions whatsoever. So it then goes down to adult children of the patient, no particular order. It's not the oldest. It has nothing to do with gender. It's a majority of those reasonably available. A parent of the patient, an adult brother or sister, and any other relative of the patient in descending order of blood relationships, so genealogy relationships kind of stuff. And there's one further one, and that's a special person who knows about the patient. He's been present or she's been present in that life of the person. And they know about the person's values. And if we can identify such a person, they can make decisions for a patient who lacks capacity. And it's an important source of information about what that person would want under these circumstances. There's a limitation. They cannot make decisions to withhold or withdraw life-sustaining treatment. So again, my quote, this is a really important thing. It's all about the diagnosing disease and providing treatment within a moral context. This is my second favorite quote. This is from a early 20th century philosopher back in the teens, I think. The essence of critical thinking is suspended judgment. The essence of this suspense is inquiry to determine the nature of the problem before proceeding to attempts at its solution. So you really have to do the information gathering. So clinical ethics consultation, as I said, is a process. We need to establish relationships with the parties involved. The person who calls for an ethics consult is probably someone most consultants know of or know about or part of the healthcare team. And it's very easy for those of us who work in healthcare to sort of take that side if we're not careful. But ethics consultants are careful. They want to get the relationship not only with the healthcare team, but they need to have a relationship with the other, wherever there is this disagreement. If you don't have a trusting relationship, it's very hard to get people out of the donkey position where they just got their heels dug in and they're not moving, or they're not listening, and that's the biggest problem. The listening part is really part of the communication issue, and so often that is really the problem. It's bad communication, not bad, poor communication between the provider and the family, and it often has elements on both sides of that equation. But as that last quote says, you need to gather information before you come forward. And we have this fancy checklist. It comes from the textbook by Johnson, Sigler, and Winslade. It's called Clinical Ethics, A Practical Approach to Ethics Case Consultation. And it has what's called the 4-box method that these people have developed. Now, Johnson was a Jesuit priest. Winslade's an internal medicine doctor, and the other one, Johnson is Sigler Winslade, was an attorney. But these guys got together. They're all philosophers and academics, but they got together and had this textbook. And this is very practical. This goes through the medical indications thing on that top left. You know, all of these questions. Now, I told you who the consultants were. They are chaplains. They are nurses. They are other healthcare providers and physicians. Not everybody has healthcare knowledge. That's part of their training. They generally have some conversational understanding, but there are many times when you get a particular case presented, you need to go through this checklist to obtain appropriate medical indication, because you got to really understand what's wrong with a person and what the implications of that illness are. You know, so it asks you, is the problem acute or chronic? Is it critical, emergent? Can you fix it? You know, what are the goals of treatment? All of these things are truly important, and that's just a factual bit of information. The patient preferences side is about patient autonomy. This, I told you about that 4-box thing, or that 4 principles thing: autonomy, non-maleficence, beneficence, and justice. So knowing what things the patient may have expressed about their preferences is important. Well, most of the time, the patients that we're dealing with are not capable of their own decision making. So that's why who's the right decision maker is a critically important question. And the right person from an ethics perspective is someone who knows the patient very well. Okay? That may or may not be the statutory algorithm. So sometimes we have to facilitate conversations among several different people, some of whom really have true authority and others who have really strong opinions. The quality of life decisions are a value judgment. Now, my decision, question or determination about what's right for you may not comport with your idea of what's right for you and what's important to you and what quality represents something that's acceptable to you moving forward. So how you get this understanding involves that conversation, and if you don't have a trusting relationship between the consultant and the parties involved, you're dead in the water. What you're really trying to establish, though, in this conversation is communication between the two parties who are now in disagreement. If there's a lack of trust, that communication is really, really challenging. So, as I said, it's a process. You establish a relationship, you gather information for all sides, you use the checklist. We have this conflict resolution as part of the conversation. Eventually, we're trying to get enough information to do a moral analysis. Now, it's important to every consultation. It's not always the way in which the conflict gets resolved by coming up and saying, well, this is right and that's wrong, or this is more right or more acceptable than that particular choice, both of which happen to be bad. But it's about that conversation and the conflict resolution that can occur, but then we're challenged to do a personal moral analysis. Now, as the medical director for healthcare ethics for an organization, we have there are a couple of things I do, and one is just to act as a sounding board. And when the decisions that are being addressed are about life-sustaining or life-threatening decisions, we absolutely not only encourage but require conversation between several seasoned ethics consultants who can reflect one with the other on how they see the problem. And there's almost no time when I have that conversation I will learn something or bring me back to a point where to consider another perspective before I write this thing up. So now let me go back for a second. In my particular organization, it's not done by committee. There is an ethics committee, but there's a separate consult service. And that we think that's important because it establishes some criteria and a certain level of not so much expertise. You know, we're qualified to do things by the three-legged stool: education, training, and experience. And all of those things are important, and not everybody who has an interest has all of those criteria, and that's why we have a pretty rigid defined training program. So the existing frameworks could be the four principles, but it might be any one of those other ways of thinking about ethical, what's right and what's wrong. As I say, you have to be open to other perspectives, and that has to do with being able to recognize and deal with and acknowledge your own biases. Everybody has biases, none are wrong, but we do have them, and they're unique to each of us. And being aware of your bias is critical. Some of our patients may not appeal to everybody. They might not be clean. They might not be behaving in a way that you find acceptable. There are just all kinds of characteristics that can skew the way you think about people. We all make judgments, but we need to be careful about that, particularly in ethics case consultation. And then we're going to make a recommendation. We do not make treatment decisions. We do not give legal advice, and we do not address risk options. We're very much aware of all of that, but we couch our recommendation using ethics-based language. I once was on a panel with a bunch of people that was primarily a Christian religious-based discussion. And a couple of the people on the panel were ethicists, like myself and another friend of mine who was a real expert, no question about it. And as part of this, and when I introduced myself, I said, I am a person of faith. However, I will not use the language of faith. I will use the language of secular humanism, if you will, to address it. And I got challenged about a couple of times in that thing. And when I talked to the pastor afterwards, he said, let's go for a walk. So we went for a walk, and he said, well, how can I get people to see it my way? I said, well, for some people, you have to use the secular language. And if it's true, or if you can justify it, you can do it using whatever language you choose. So that's why we use the secular language as opposed to a divine command kind of approach. So I'm through with the formal part of this in terms of what I think is sort of a background. And I wonder if anyone out there has a question at this point, because the next step in this will be to look at some cases and have you all opine about what you think is the right thing to be done, or how that program ought to progress in order for the right answer, the most morally appropriate answer, can be arrived at. So anybody got a particular question? Now, the mic. Where is it? And who's going to get it?
In here, and we'll get another one.
And remember, right up next to your lips, or I won't hear it. Marty, you're on the front row. Why don't you get started?
I'm going back to that slide where you listed all the people who would speak, and you said the court trumps everybody, and then it goes to the next one, and then if the patient can't make their own decisions, it goes to whoever they've listed in their thing. how come the court trumps everybody else, and under what conditions would they insert themselves?
Usually the court's involved in things because there's some issue that's caused a legal action. Somebody's approached the court about guardianship or something of that sort. And it's the law. That's why it's like that. And you might not agree with it, but that's the way it is. So this is about the difference between who knows the patient best and who the law says is the authorized person. So typically, we're not involved in that. Occasionally there's a guardian present that's been appointed, and whenever you have documents, you need to read them because they can vary. And just because somebody's a guardian doesn't mean they're authorized to make all decisions. There may be some stipulation within the document. The other thing is, many times we're presented with a power of attorney. And the person says, I'm this person's power of attorney, I make the decisions. Well, a durable general power of attorney does not make anybody authorized to make medical decisions. And advanced care plans have again, statutory thing about how it has to be signed. It has to be signed by the patient, it has to have 2 witnesses. Now, in Virginia, the 2 witnesses can be one of the people or both people who are named as agents, because you can name a primary agent, and then if that person's not available, a secondary agent. There are all kinds of ways. You've got to read the documents. You have to look at them for validity. But a durable general medical power of attorney, which is generally about financial things, has no bearing on medical decision making. Yes, ma'am. Somebody else, yes, in the back. And I see a few men here. I made a similar presentation to the men's coffee a number of months ago, and I apologize for some of the same slides, but I've tried to approach it from a different perspective on this occasion. Yes, please.
What is meant by the quality of life, and what factors are used to make that determination?
Say that again for me, please.
What is meant by the quality of life, and what factors are used to determine that status?
Okay. It's important for healthcare providers to recognize that a patient's values may not be theirs. And so we might see something, we being healthcare providers, and that's not what I do now, but something that would not be acceptable to us, and particularly providers become distressed when they're asked to provide aggressive treatment for a patient for whom there's no reasonable medical expectation of any meaningful recovery or ability to interact. And so that becomes often the thing that triggers a case consultation request. Finding out about the patient's values is one of the jobs of the ethics consultant. It's so very important to have that conversation, we don't take sides, okay? This is about trying to figure out what's the right thing for this person at this point in their illness at this time in their life. And so finding about patients' values is important. Now, if you remember in the presentation, autonomy is the right to choose from among medically appropriate and morally acceptable options. It is not the right to demand. There is a provision in the law that allows physicians to say, this is wrong, it's not medically appropriate, and I'm just not going to do it anymore. There's a process. Virginia is one of a few states, probably 10, 11 in the country, that have a statute that says medically and ethically inappropriate treatment is not required. And then it goes through a process that's very complicated, time-consuming, and from a process perspective, a real pain in the neck. But it's important that it be followed because you need to, one of the things it says is you have to give people time to find somebody else who doesn't agree with that. They'll take care of you. And you have to give them 2 weeks to do it. So the physicians are required to provide this treatment. They say they just absolutely think is the wrong thing to do, and it can't accomplish their goal because you can't discontinue life-sustaining treatment until this process is completed. So the values of what enter into that discussion and getting people to have the conversation and to listen to each other is important. So I don't know if that completely answers your question, but the values become part of the conscious considerations in what's the right thing to do. Someone else?
Doctor, do you use the same presentation?
Close to your mouth. Can't hear you, John.
Do you use the same presentation when you talk to medical groups?
Can't hear you. I know it's on, but you got to get it close.
I'll shout. Do you use this same presentation when you talk to medical professional groups?
Yes, sort of. Most people, it's a different audience, you know, as you're referring to, and so not completely, but it is basic stuff. And I'll say this: in my medical education, I remember one lecture on a Saturday morning about medical ethics. And I think I'm a reasonably ethical person. I tried to do the right thing. And how I got involved in medical ethics is I was on the OR committee, and it was a morning meeting. And it was at the doctor's dining room. You go through the chow line, and you pick up your plate of eggs and your hash browns and your bacon and so forth, and you back into the doctor's dining room. You turn. I didn't recognize a soul. It was the wrong Tuesday. It was the ethics committee. They said, well, sit down and eat your eggs. And as a result of that, I thought, this is really kind of interesting. I think it might be important for me to, know more about this and so forth. Now, just as another comment, I've been interested in moral thought just as a person for a long time, but never on any detailed level like this until I got involved then. But it's one of those things, I said, well, do you need somebody to represent surgery on this committee? Well, yeah. And next thing you know, you're the chairman of the committee, and you have to go off and do some education because I hadn't really had any formal education about this. And so I ended up going up to University of Virginia for an intensive, and Georgetown for a week or so, and Rush University online and out there, and so that's how I got involved in ethics. But I don't know how I got involved. So that's the answer to your question is no, it's not the same lecture, but a lot of people aren't very knowledgeable on a formal basis about the process that's involved in resolution of ethical conflicts and dilemmas. That was a long answer for a short question. Somebody else?
Good morning, and here I am.
Oh, there you are. You're sitting down.
And first, I want to thank you very much as a fellow resident for being willing to come and do this wonderful presentation, Dr. White. So my questions, how does one go about finding a ethics consultant? That's part of it. Number two, does it require special training? Number three, is it a licensed position? Does it need to be a licensed position? And is it always a medical person, a doctor, a therapist? Could it be a lay person without medical training? Is it a special designation?
Okay. First of all, kind of go backwards. No, it's not a licensed position. I mentioned it earlier that within the system where I work, it's a separate service from the ethics committee structure. And we did it intentionally that way because as many regional systems are, they're community hospitals that come into within that umbrella, and they bring with them their own culture, their policies and procedures and things of that sort. And they may or may not be sort of on the same page in music in terms of the credentialing. So that was the next part. We do believe it to be important that people who do this should be qualified. And so the qualification is, first of all, real interest and dedication. That's minimal, though. You have to have the factual background in terms of ethical theory. You have to have some skill set in terms of conflict resolution. There are internships that are full-time. There are fellowships that are full-time and maybe up to 2 years. Typically, those people have advanced degrees. They're within an academic environment. Most don't end. Only a few of the people with the qualifying degrees end up doing bedside case consultation because of the process that's really needed in order to do it and do it well. There is a national organization, the American Society for Bioethics and Humanities, that has a credentialing board that they have established, and so I'm a healthcare ethics consultant -certified. And that has an exam that's done. It certainly doesn't examine process skills in the way that's needed, and that's why we at my institution and many places that do it well have a separate service that does this. Now, I'm the only person who doesn't have another job. Okay? These are all volunteers in my system. Some systems have full-time people. They are rare. And so the concern, and it's often in the peer-reviewed literature, is about who's doing it and how qualified people are and the decisions that come down. But I think you can say, because I didn't practice in Richmond, I don't intimately know things about Richmond, but I do know some of the people that do it because I've been involved at the state level and in committees. And I know that VaCCRA has a very, very well qualified person in VCU. I don't know anything about the HCA system. I've been a patient there, but I don't know anything about their ethics. Now, there are some statutory requirements that have to do with protected health information, this HIPAA thing that you're now used to sign a release when you go to see the doc. But that's about respecting patient autonomy. That's where that comes from. Anyway, have I answered all the questions? What? How do you what?
How do you find someone?
Oh, your question. Typically, the requests come from the healthcare side. So they know from their education within the orientation right on down to the day-to-day practice. And there's an order set in the electronic medical record for an ethics case consultation and a section that you're supposed to explain the reason for it. Almost never filled in, but sometimes we'll get an inquiry. Usually it comes through the patient advocates because people have complained to somebody about something and they're making noise and they get a referral to this. And these people are pretty skilled in conflict resolution and in kind of getting to the bottom of things to figure out what's going on. And so often it'll be a referral from the patient advocates. But anyone can request an ethics case consultation if they have some standing in the case, some involvement. Any other questions before we get started on the couple of cases? Let's see if I can get the right thing up here. How do we do it? How do we get it back here? What happened to our... can you get us back up so I can see my presentation? Because it seems to have disappeared. Thank you. I'll get out of your way. Well, I'm glad it's not just me. Anyone else have a question while we're technically trying to get to the bottom of this? Just speaking of technical issues, I came over today, I had all my information on a flash drive and I plugged it in all fat and happy and thought I was just going to pull it up and I couldn't find it. Fortunately, last night at 8 o'clock, I put a copy of it in an email to myself and was able to get it up. And it really was a last-minute decision. I don't think I've ever done it before, but somebody was looking after me. How in the world did we get there? Okay, let's see what happens here when I try and do this. Okay. Here we go. We have a case. Here's the scenario. Mr. Smith is a 53-year-old patient admitted for surgery for a large intracranial mass, brain tumor. She's married, has lived apart from her spouse for about 15 years. 2 adult children, 30-year-old son, a 20-year-old daughter, and an adult brother who's present at the bedside. She also has 2 sisters who live out of town. There's a durable general power of attorney naming her brother as her agent. In the holding area at the time of admission, she's heard to say she wants her brother to make decisions for her if she can't make her own decisions. Well, there's some luck. That almost never happens. The tumor is surgically resected and determined to be a meningioma cancer. When the patient recovers from the anesthesia, she's found to have had a stroke. She's obtunded completely out of it and on the mechanical ventilator. She's comatose and unable to communicate. Ethics consultants called to identify the person who should make decisions for this patient and to discuss extent of treatment and goals of care. So, using the 4-box method, let's see if I can get there. Wrong direction. Okay, I put it up beside it. Can you read that? Okay, you have the medical indications. What questions do you have? Because you need to have medical facts. What do you know about this person's illness, and what don't you know? Well, how about on the prognosis? You know, what's the likelihood this person's going to wake up and be able to tell you something? That's an important thing to know about. Are there critical decisions to be made at this time? You know, we don't know that from this, but that's an important piece of information about how urgently you need to try and find the right person and come to this decision. I turned this back on and I didn't mean to. I'll send it to voicemail. There we go. Sorry. The first time I had it turned off when I came over, because I didn't want interruptions like that, I had to turn it back on to get to the Gmail and all three. It was a mess. Anyway, so, you know, the real, what's the question that's being asked here? Be specific in your answer there. Because the question is assisting to identify the persons who should make decisions for the patient and to discuss stuff. What do you know about patient preferences? Say again? She said something about her brother, okay? Now, there's some technical things about this. What constitutes a valid oral advance directive? Well, that's a mouthful, but it's very specific in the law. Do we know some information that's important? We do. And if this was documented in the nurse's notes, it would be a really important piece of information to come up with. So that we know that might be the case, that because it's been recorded. So we have the statutory requirements. How about this spouse she's been apart from for 15 years? We don't know whether there's a divorce action filed. Because if it's a divorce action filed, he's automatically disqualified. In the absence of an advance directive, if there's no divorce, he's the authorized decision maker. And I've had people try and come in who've been apart a long period of time, had other families, want to get in the middle of all this. And how you navigate that is all a part of the conflict resolution process. That's the kind of information you have to process in one of these kind of things. So we already know a lot about the patient preferences in terms of one specific thing. She was heard to say this thing. Now, if that had been made to the attending physician, well, he was in there doing his pre-op chat, and how you doing, Ms. Smith? And there were a couple of nurses in the room, and they wrote it down in the medical record. That would be a valid oral advance directive, and he would have legal authority to make decisions for the person. Now, the person who's the authorized decision maker is solely responsible in most cases because it's identified as a particular person. We live in community. There are families that are engaged in all these conversations, and that's a part of the challenge of conflict resolution through an established relationship and trust, and that lets you have, a real conversation. And then basically is, I'm really sorry your mom's sick. Tell me about her a little bit. What was she like when she was well? Just different ways of going forward. So that's one scenario. Let's see. That's the wrong direction. We have another one here. We have Ken, who's a 52-year-old man who's lived in a nursing home for the past 15 years, severely cognitively impaired. While being transported to get his teeth fixed, he's involved in an accident and he's taken to the hospital. He's treated for traumatic injuries to his head and neck, and after 3 days of treatment in the ICU, he's on an endotracheal tube and a ventilator. He's lost all of his meaningful neurologic reflexes. The physicians conclude that he will not survive. They plan to test him to confirm brain death using neurologic criteria. He has two siblings who have been making decisions for Ken over the years, and they're informed of this concern in the process. The older brother objects strenuously to this testing, tells the attending he can't go forward with this exam. He demands continued aggressive treatment and to continue the full code status, even in the event of cardiac arrest. So what should we do? Now, just to make a quick comment about the brain death thing. There are two statutory ways to determine death. There's the classic, no breathing, no heartbeat, and it's irreversible. That's it. Brain death, on the other hand, is a determination of a lack of all neurologic functions of the brain, including the brain stem, that is permanent. And there are specific ways to conduct this examination. There's a recent position paper that was put out by a conglomeration of different groups. American Association of Neurology, Pediatrics, Critical Care, Surgical Critical Care, a bunch of them. And it was a position statement that is pretty much the standard. It was based on, initially, if you recall, there was the Harvard criteria back in the 60s when this first thing was brought forward. It's really not about organ donation. It's an important part of the organ donation system, but it's really about the determination that this person has no chance of recovery ever, and that they cannot breathe without mechanical and medical support. And if that's not there, they wouldn't survive. The problem with it is that these patients don't look dead. They're on a ventilator, chest going up and down. They got the monitor, squigglies going up and down. O2 saturations are there, and so forth and so on. And they just look the same as they did before you did that examination. And so families sometimes have a real tough time with this. And that's why the communication part of this is a really important process. So here's the question. Does this brother, who might be an authorized decision maker, have the right to say, you must not do this? You must not conduct this examination. What do you think about it from an ethical perspective? Can the doctor go forward, or should he do, in the face of this objection by the brother? And he's adamant about it. He's even threatening to go to his lawyer. He's threatening people.
Okay, is this the case where they might bring in the courts?
No. You might bring in the local police department to make it be a safe environment, or the hospital security people if he's physically threatening people. But on the other hand, from an ethics perspective, there is no need for permission. Anymore there's a need for permission, put your stethoscope on somebody's chest to make the classic determination that someone's deceased. There is no mention of it in Virginia statute. There is some mention of things in other jurisdictions. But from an ethics perspective, it's simply a normal part of medical practice to make an appropriate determination. The law is very specific about who can do it. It has to be a neuroscientist, neurologist, or neurosurgeon, or critical care specialist, all of whom have training in this particular examination. And it's very detailed and has to be done following every single step of the way and well documented in the record. That's the basis for some of the concerns that have been voiced in the past. Now, we're past that 11 o'clock hour. Charlotte promised we were going to be respectful of people in terms of their time. So I'm available to have a chat if you want to come up and ask some questions or talk. And I'm here if you want to talk some more, but I won't be hurt if you go out the door either. Thank you for your attention.